You tell them?
How do they know?
Let that come down. Sound, should we ask people on Zoom? See if anybody offers an answer about these. Okay. All right. Okay, good. All right. It is my pleasure and honor to introduce my colleague, Dr. Ilana Raymer-Bass, Assistant Professor of Medicine, as our endocrine grand round speaker today. She attended Northwestern University for her undergraduate degree. Since then, her training has been at Mount Sinai, having completed medical school, residency, and her endocrine fellowship in our department and division. Dr. Raymer-Bass has other ties to Sinai. Her mom is an esteemed faculty member of the Department of Pathology. We are indeed lucky that she has such roots in our institution, as this might have swayed her to remain. She's published in a variety of endocrine areas, from diabetes to in vitro fertilization, PCOS, and case reports on both Cushing's and thymoma. She spent her scholarly year working on the intersection between breast cancer and diabetes under the tutelage of Drs. Derek Leroy and Dr. Emily Gallagher, and is first author on a publication related to that work in diabetes medicine. I had the distinct pleasure of working with her on a study of the expression of dopamine receptors in patients with resistant galactanomas. It's in some sort of quirk of fate. This publication, we've been submitting it and resubmitting it this morning. After, I don't even want to say how long. You need persistence in academia. It looks like it's accepted. So that's very, yes. In this work, as in many of her other projects, she's mentored trainees, even when she herself was still in training. And one of our current first-year fellows, Julia Ferreira de Carvalho, was mentored by Dr. Raymer-Bass on that pituitary project. Ilana has garnered a number of awards at various stages of her training, including AOA and Gold Humanism Award in medical school, the Dr. Harold Lancourt Biomedical Research Prize, Graduation with Distinction, and the Mount Sinai Alumni Association Leadership Award. As a fellowship in training, I think this was during the pandemic, she received the Star Employee Recognition Award. Most notably, she received the Teacher of the Year Award from our endocrine fellows in 2023, not quite 2 years after she completed her fellowship. So that was quite a trajectory from being a trainee to being Teacher of the Year voted by the trainees. I want to emphasize that Dr. Raymer-Bass is one of our junior faculty members, in spite of the accolades and many publications. Her career is just beginning, and I'm excited to watch it blossom. She also has a long-standing interest in lipids metabolism and is the lead for our weight management program at Sinai Morningside West. Today, she will be speaking on the metabolic consequences of lipodystrophy. I've been learning from Dr. Raymer-Bass since she was a fellow not terribly long ago, and I'm certain that today will be another treat for all of us.
Okay. Thank you for that introduction. It's so nice to be here. And today I'm going to be talking about lipodystrophy, which was something that I really wasn't so familiar with. And then I have a very interesting case, which I'll go over with all of you, and it kind of inspired today's talk. And so I hope that you've all learned a lot from this patient as much as so. I have no disclosures, and this is an outline of my talk today. So I'm going to go through the case. I'm going to go through the definition and classification of lipodystrophy, pathogenesis and major complications. I'll talk about acquired lipodystrophy, inherited lipodystrophies, the epidemiology of lipodystrophies and underdiagnosis of this condition, diagnostic clues and testing, management and treatment strategies, and then I'll close with the end of my case and some conclusion. So this is the initial history. This is a patient who presented to pediatric endocrine. She's 15 years old, from Bangladesh with history of obesity, who initially presented with secondary amenorrhea. She underwent menarche at age 12, but had 1 day of bleeding and then no further menses between 2016 and 2019. She noticed hair growth that started on her face at age 11, deepening of her voice that was very distressing to her, hair thinning on her scalp, and her exam, the pediatric endocrine notes, note hirsutism and clitoromegaly. These are the initial labs that the pediatric endocrinologist sent, and they reveal elevated testosterone level of 315, severe hyperinsulinemia, insulin level of 77, A1C of 5.9%, consistent with prediabetes, elevated LH to FSH ratio of 21:11, low normal estradiol, and elevated androstenedione. The peds endo went out to do an APT stimulation test to rule out congenital adrenal hyperplasia. And what you see is an appropriate rise in cortisol when post-introphin is administered. And then you see a mild rise in DHEA sulfate and 17-hydroxypregnenolone. So this is consistent with the functional adrenal hyperandrogenism of PCOS and not consistent with non-classic 3-beta HSD deficiency, where you would see 17-hydroxypregnenolone levels like above 4,000. So then they went on to do a DEX suppression test. And here in the setting of being given dexamethasone, a coated corticosteroid, ACTH appropriately suppressed, and there was no suppression of testosterone and androstenedione, showing that this is not ACTH mediated, and instead the hyperandrogenism is coming from a different mechanism in this case. So that points towards PCOS, so you do have to rule out any kind of virilizing tumors because of the degree of elevation of testosterone. So pelvic ultrasound was done that showed enlarged ovarian volume, sparse follicles. CT, abdomen pelvis showed no adrenal mass. MRI, abdomen pelvis, also unremarkable. Karyotype was normal, 46 XX. And so the peds endo started to treat her as severe PCOS, started OCP, metformin, eventually added spironolactone, and then she established care with me in 2023. On my exam, I noticed that she was obese, BMI of 31, very round face, acanthosis of the cheeks, neck, underarms, very severe, terminal hair growth of the chin and neck area, dorsal cervical fat pad, and a very deep voice. Her family history was notable for PCOS in both of her sisters, diabetes in her mother, and pre-diabetes in her father. So I repeated labs, and the DHEA sulfate was normal, triglycerides were elevated at 239, prolactin was normal, testosterone was markedly elevated, 291, on an oral contraceptive. And the androstenedione was 194, which is elevated, and then I did the oral glucose tolerance test, because if you remember, her A1C was consistent with pre-diabetes, but her oral glucose tolerance test was markedly abnormal, consistent with type 2 diabetes. So at this point, I'm honestly just suspicious that something wrong is very wrong, but I had no idea what to do next. And I just felt like this was not like ordinary PCOS. So I phoned a friend and I called Andre Junaid. And the conversation went something like, well, I have this young woman. I feel really bad for her. She's very distressed about her deepened voice. She really looks Cushingoid to me. She has diabetes, hypertriglyceridemia. And she had one question for me. She said, is the patient's buttock small? And I said, I don't really know. So I called the patient, had her come back in, put her in a gown, and examined her properly, and noticed that her calves were very muscular and her buttock was small, especially in relation to a very, obese abdomen and pushing pushing while you're hearing upper body. So that's when I started to suspect familial partial lipodystrophy. So taking a step back, let's define lipodystrophy. So it's a clinically heterogeneous acquired or inherited disorder characterized by selective loss of adipose tissue. So we're talking about lipoatrophy, loss of the subcutaneous adipose tissue, like you can see in these photos. And in some cases, there's lipohypertrophy as well, where there's accumulation of visceral fat. And visceral fat is more lipotoxic than subcutaneous fat. So there are 4 different subtypes of lipodystrophy. Like I said, it can be congenital or acquired, and then the pattern of lipoatrophy or subcutaneous loss of that fat tissue can be generalized, meaning it affects the whole body, or partial, just like patterned, like some areas of the body, not the whole body diffusely, and that leads to these 4 subtypes: congenital generalized lipodystrophy, acquired generalized lipodystrophy, familial partial lipodystrophy, and acquired partial lipodystrophy. So let's talk about the pathogenesis of what's going on here. The leading theory of why this lipoatrophy and loss of fat leads to metabolic dysfunction is the lipid overflow ectopic fat deposition model. So in healthy people without lipodystrophy, fat is stored in subcutaneous adipose tissue. And when it's stored there, it's metabolically safe fat. It doesn't accumulate in the organs, and then that leads to healthy function of the organs and normal metabolic profile. In patients with lipodystrophy, there's loss of that subcutaneous fat, so fat cannot be stored properly and in those safe areas. So it overflows and it's deposited in ectopic areas, referring to organs. So fat can be deposited in the liver, it causes steatosis, steatohepatitis, can be deposited in epicardial fat leading to cardiomyopathy, atherosclerosis, in muscle leading to insulin resistance, or in the pancreas leading to beta cell dysfunction and diabetes. And that's what leads to this altered metabolic profile. And the severity of metabolic dysfunction is proportional to the extent of fat loss, because if you have more subcutaneous fat loss, then there's less place to store your energy or your fat. And so more ectopic overflow. There's another component here. With the loss of adipose tissue, you also lose important adipocytokines that are released from the adipose tissue. So one of those is leptin. It's a hormone secreted by adipose tissue. It signals satiety to the hypothalamus, suppresses appetite. Also, it regulates energy expenditure and insulin sensitivity. So when you have loss of that functional fat mass in patients with lipodystrophy, there's reduced leptin, and so your brain thinks that your body is starving. It induces increased appetite, hyperphagia, reduced energy expenditure, and worsened insulin resistance, which you can imagine if a patient is hungrier and taking in more fat, and then there's nowhere to deposit the fat safely, then it worsens that overflow of ectopic fat. So this slide puts together the whole pathogenesis, where at the top, the central driver of disease is the lipoatrophy, the loss of adipose tissue that leads to that loss of energy storage and ectopic fat deposition in the pancreas, liver, skeletal muscle, which leads to impaired insulin secretion and insulin resistance and compensatory hyperinsulinemia. And then you have the decrease of leptin, which causes hyperphagia and further worsens. So what are the major comorbidities and complications of lipodystrophy? The metabolic complications are hyperphagia, dyslipidemia with increased triglycerides, low HDL, insulin resistance, diabetes, acanthosis nigricans. The reproductive comorbidities are PCOS-like features, oligomenorrhea, hirsutism, and then I alluded to this, but the organ complications are MASLD in the liver, heart disease with hypertension, cardiomyopathy, arrhythmias, and you can get proteinuria at the level. So now I'll talk about the acquired lipodystrophies. The first is acquired generalized lipodystrophy. So again, generalized meaning affects the entire body. This is progressive generalized loss of fat tissue that usually begins in childhood or adolescence. It's very rare, female predominant, And there's a few different subtypes. So in about 25% of these patients, it's heralded by development of pediculitis, which are like subcutaneous nodules that can form, and then they become more generalized. Generally, in those patients, the fat loss is more mild and there's less metabolic disease associated. In 25% of patients, there's some link to autoimmunity, like the patient might also have juvenile rheumatoid arthritis, juvenile dermatomyositis, Hashimoto's, and they can have these positive anti-perilipin-1 autoantibodies. And then in 50% of patients, it's idiopathic, and we don't know the etiology, why this develops. And then we have acquired partial lipodystrophy, so this only in fact affects parts of the body and refers to progressive fat loss in a cephalocaudal pattern, so it affects the face preferentially. And actually some patients, I'm blocking this picture, but can gain fat in the hips, buttock, leg area. And this shows the loss of fat in the face. Also onset childhood and adolescence with strong female predominance, and the main complication here is renal disease, especially membranoproliferative glomerulonephritis in about 28% of these patients. The metabolic complications are less common, and this is associated with autoimmune disease. So you can see low serum complement C3 levels and presence of C3 nephritic factor autoantibody. Then, just to be complete, there are other forms of acquired partial lipodystrophy, like HIV-associated lipodystrophy, usually associated with some of the older medications used for treatment of HIV, like protease inhibitors, and they can get the loss of fat in the face and accumulation of fat elsewhere, like intra-abdominally. And then there are certain medications that can cause a very localized lipoatrophy, like we're familiar with insulin or corticosteroids. You can also get this from recurrent local pressure, and this is just focal loss of fat. So now changing over to the inherited or genetic lipodystrophies. Congenital generalized lipodystrophy, this is autosomal recessive in inheritance, very, very rare, about 1 in 10 million. And because it's congenital, this starts in infancy or at birth with generalized fat loss. These children can have hyperphagia, accelerated linear growth, advanced bone age, prominent umbilicus and umbilical hernia with underlying like splenomegaly, hepatomegaly. They can get very severe acanthosis, hypertriglyceridemia, diabetes, steatohepatitis, and the women can have that PCOS. There are many subtypes that have been identified with correlating pathogenic genes. They all have to do with like biosynthesis of triglycerides and normal adipogenesis. So these are some of the genes that have been elucidated. And then familial partial lipodystrophy, this is usually autosomal dominant, but there have been reports of autosomal recessive inheritance. These patients have normal fat distribution in childhood and then develop the fat loss around puberty. There's preferential loss of fat in the arms and legs, sparing the trunk and face, and very much associated with the metabolic dysfunction that I referenced. So there are also many different subtypes of familial partial lipodystrophy, and I included their known gene defects here. The first two, Oberling and Dunnigan varieties, account for about 95% of familial partial lipodystrophy. The first one, there's not a known gene, it might be polygenic, and this, classically, there is fat loss in the lower extremities and intra-abdominal fat gain, and there are ledges where you see like a well-demarcated differentiation between the areas of fat loss and the fat gain. And then type 2, Dunnigan variety, this is the most prevalent. There's a defect in the LMNA gene, which encodes lamins A and C, which are critical for the nuclear membrane. And these patients typically get that Cushingoid appearance with gain of fat in the neck, like supraclavicular dorsal cervical region. The third is a defect in PPAR gamma. And this leads to more severe metabolic issues than the first two varieties. Here's a picture of the top three. So here in type 1, like I said, there are these ledges where you see like a sharp demarcation between the area of fat loss and fat gain. Type 2 is where there's the Cushingoid appearance with the weight gain in the neck region. And then the third variety is less pronounced fat loss, but more metabolic dysfunction than type 2. And then this is a summary slide of everything I said, just to keep it all organized. These are the inherited lipodystrophies. In this column, you have the generalized autosomal recessive inheritance with these genes implicated, and the genes all play a role in storage and formation of fat. And then because it's the generalized congenital version, there's loss or absence of body fat from birth. And this is associated with metabolic complications. And then you have your familial and partial lipodystrophy, both autosomal recessive and autosomal dominant varieties. There are various mechanisms by which these genes cause lipodystrophy, and typically there's absence of fat from the limbs and accumulation in the intraabdominal area. So the epidemiology, these are obviously rare, 1.3 to 4.7 cases per million, but the true prevalence is likely higher, especially for familial partial lipodystrophy, where it might be as common as 1 in 20,000, but we're often misdiagnosing these patients as just metabolic syndrome and obesity. So this is definitely under-recognized in our patient population in diabetes clinics. And what are some reasons for underdiagnosis of this condition? So sometimes there are subtle phenotypes. Sometimes it just looks like ordinary obesity or, or weight gain. And in men in particular, because of the muscular build that some of these patients have, they could just be mistaken for having a muscular body habitus. And then limited provider awareness. Like if you don't know to look for it, you're not going to diagnose it. So it's really eye-opening. Like once you see a patient with this condition, you are more likely to look for it. And in my practice, I definitely have identified a handful of patients that likely have this condition that I wouldn't have known about before this patient. So what are some clues you can all use as you go forward to think about this when you're seeing patients? So anybody with antibody negative diabetes with very high insulin requirements, like above 200 units a day, you should be thinking, is there something else going on here? In my practice, I have a patient who literally came to me on 500, 300 units TID, so 900 units of insulin a day, super muscular guy, and I was like, maybe he has this, and long story short, put him on some insulin sensitizers, and now he's down to 125 units of insulin a day. So definitely that's something to think about. Ketosis resistant diabetes, so your patients who are poorly controlled diabetics, but don't go into DKA. Acanthosis, especially if it's more like pronounced, like in my patient that I'm talking about today, it was really just very striking how her acanthosis spread to her cheeks and neck and beyond just like the neck area that we commonly see. Severe hypertriglyceridemia, especially if they're poor responders to conventional therapy, history of pancreatitis from their hypertriglyceridemia, hepatomegaly, elevated transaminases, or imaging showing hepatic steatosis, which I know could be many patients. So it's kind of like this plus a body habitus that makes you think of lipodystrophy. And then some other clues, family history. So I do sometimes ask people if they look like anybody in their family, like if their bodies are similar to anybody in their family. When I asked this patient, she said, yeah, my paternal aunt, I look a lot like her, and everybody tells us that. You also want to look for the prominent muscularity, visible veins, ask about hyperphagia, night eating, food seeking. My patient tells me all the time like that she just finishes a meal, thinks about the next one, has food seeking behaviors where her sisters don't. Hypogonadism in men, amenorrhea in women, and then specifically for familial partial lipodystrophy, again, Cushingoid features, but lack the other stigmata of Cushing's, like no striae, no easy bruising, no muscle weakness, and then the small buttock sign, which really should be coined the Andrea Dunave sign. So those are some things to think about. And then the diagnosis is really a clinical diagnosis. So you really just want to look at the patient. If you suspect based on body habits, think about all the things I just listed and ask questions about the timeline of their weight gain, development of diabetes and all their complications and comorbidities. Ask about family history, autoimmune disease for the acquired versions. On physical exam, look for fat redistribution, muscle hypertrophy, hepatomegaly, acanthosis, that Cushingoid appearance. And then there are tests that can be done. So a lot of us don't own calipers to do this, but you can measure someone's skin fold thickness, and that can be suggestive of lipodystrophy. Really just for research purposes, you can use bone density and or DEXA scans, not for bone density, but for looking at like the skin thickness and whole body MRI. Labs and genetics are helpful but not required. And then additional testing that you can do, you want to do the labs to look for the comorbidities that I already outlined: fasting glucose, A1C, or a glucose tolerance test, fasting lipid panel, ALT, AST, FibroScan, urine protein, look hormonally at their LH, FSH, total testosterone by LCMS, and then you can measure leptin, but it's not specific or required for the diagnosis. And genetics are often helpful to confirm if you can send your patient for genetics. These, for genetic testing, these are the genes that have been found to date. The newest on the list is Notch3, which was just published this year. It's a gain-of-function mutation in patients with familial partial lipodystrophy. And knowledge is still evolving, so negative genetic testing does not rule out lipodystrophy by any means, but it is helpful to send these patients to see what can be found. Things to consider if you think this patient might have lipodystrophy: you want to rule out other severe insulin-resistant syndromes, pancreatic diabetes due to pancreatic insufficiency, PCOS, other endocrinopathies like Cushing's, acromegaly, congenital adrenal hyperplasia, conditions that cause weight loss because it can appear like someone is losing weight. So thyrotoxicosis, adrenal insufficiency, HIV-associated lipodystrophy, and malnutrition or cachexia from other reasons like blood. So thinking about management for these patients, you want to recommend lifestyle management first and foremost, balanced, low-fat, low-carb diet to help with the lipids and the metabolic dysfunction, regular exercise, avoid alcohol and smoking. These patients are already at risk for things like pancreatitis and heart disease. The general approach is just to aggressively manage their comorbidities like the diabetes, dyslipidemia, and liver disease, since there's no therapies that can reverse fat loss. So for treatment of the metabolic complications, you want to use conventional agents like metformin, which has traditionally been the first line since it works for the insulin resistance component. Thiazolidinediones, these increase adiponectin and help with insulin sensitivity. Insulin is often needed for these patients, and if you require high doses, then we can use concentrated insulin like U500 for the dyslipidemia, statins, and fibrates. And then there are, of course, agents that we use all the time that they're just not really well studied in this patient population, but theoretically should be very helpful. So GLP-1 agonists should be able to help with the hyperphagia, insulin resistance, and steatosis. SGLT2s also help with controlling the patient's diabetes and help with some of the weight loss, and bariatric surgery may improve metabolic parameters. So you want to treat these patients as severe metabolic syndrome and just anticipate that they might need more medications and have higher drug requirements. For PCOS and hyperandrogenism, the first line is to use OCPs, but to avoid estrogen if they already have baseline high triglycerides. use spironolactone and metformin, and in refractory cases or very severe cases, you can use GnRH agonists like Lupron to suppress LH and FSH and decrease estrogen and testosterone. Side effects of giving someone Lupron is hypoestrogenism, and they need add-back therapy with giving estrogen back. And then there is a treatment called metrolactin. So this is recombinant human leptin. It's given subcutaneously via injection 1 to 2 times a day. It's FDA approved only for congenital or acquired generalized lipodystrophy, not for partial lipodystrophy in the US. In Japan and in Europe, it is approved for partial lipodystrophy. But studies do show that in patients with generalized lipodystrophy who are given metrolactin, there is improvement in A1C, in triglycerides, in fasting glucose. The main reason why the FDA has not approved it here for partial lipodystrophy is this risk of neutralizing antibodies that can form and worsen disease and cause infections. But patients who are on it, the side effects that could happen are fatigue, hypoglycemia, headache, abdominal pain. So it can really help with patients with generalized lipodystrophy, but right now, not for partial lipodystrophy in the US. So going back to our case, I sent her to genetics here, and all the genes they tested for were negative. And the explanations could be that this is multifactorial disease with some unknown genetic predisposition and environment, or that the genetic cause is just not known yet at this point. So with the help of Dr. Andrea Dunaith and Kelly, we were able to collect samples from my patient, her 2 sisters, and her parents, and send her DNA samples to Dr. Abhiman Mugar, who came last year to speak about lipodystrophy. And so he has the samples now. He's doing whole exome sequencing to try to find the genetic defect, and he says that should be back within like 8 weeks from now. So that's exciting. And then in terms of treatment, I started her on Lupron every 3 months, and her first dose was May of 24. So that's where you see this arrow pointing. And everything, I know it's probably hard to see, but this is DHA sulfate, estradiol, FSH, LH, and testosterone, everything markedly decreased. And for people who like numbers, I included the same information here as a screenshot from Epic. So her testosterone at the point where we started Lupron was 748. And then repeat later after starting on Lupron was 16. Her LH is now suppressed down from 35. Her FSH is 2.5 down from 10, and her DHA sulfate also went down from 179 to 107. So in that respect, she's doing well, but she did develop symptoms of estrogen deficiency. So we added back OCP, ultimately changed her over to HRT with estradiol patch and prometrium. Had her on metformin, but she discontinued it due to diarrhea. She can't tolerate it. Added pioglitazone. She self-discontinued that. And then I tried to put her on a GLP-1. She had symptomatic gallstones, had a full cystectomy in January 25. So now that that's out, we have her back on Mounjaro, hopefully titrating. She's difficult in that she doesn't think things are working well for her. She gets discouraged by her hyperphagia despite Mounjaro, but my job is to convince her to just titrate up to higher doses, and hopefully that will help her. And at the last visit, we also added Jardiance for her diabetes. So to conclude, lipodystrophy is an underdiagnosed cause of severe metabolic disease. Diagnosis is primarily clinical, supported by labs and genetics. Patients often present with PCOS-like features, diabetes, and dyslipidemia. Management focuses on comorbidities. Metrolactin offers targeted therapy in generalized disease, but not in partial in this country. And then early recognition and management are critical to prevent severe metabolic complications. These are some acknowledgements and references, and I'll take any questions.
That was great. You never disappoint. I have a couple of questions and then a comment. Question is, why she had a phenomenally elevated, I don't mean to compliment it, but very elevated testosterone.
Yeah.
And did she have signs of true virilization? Did she have clear
Yeah,
And why is that? Why do they get that? It sounds like it's more adrenal.
Ovarian production of,
And ovarian? Okay,
it's both.
yeah,
From my understanding, it's the insulin resistance that causes like very severe PCOS. So there's like stimulation at the level of the theca cells of the ovary to make more androgens.
and
then
zona reticularis, yeah.
And then also, I think like LH, it's also something with LH stimulation of the ovaries to make more androgens as well.
Severe hypertension. But it was a little bit adrenal too, right?
Oh,
Because,
what's
yeah.
interesting now is the VHS.
right, so some of it's coming there, yeah,
Precursor from over was getting sulfate.
right. Yeah, so we've shown, there are LH receptors in zona reticularis, so
That would be it too.
yeah, but I was also gonna say that, my new favorite test that I said, which it's a little late in her, but if you ever stop it and start it again, the GnRH agonist, you can send off these oxyandrogens, which we have it in the panel for LabCorp, and they are supposedly more exclusive to adrenal androgens. So that would be interesting just to see with or without the GnRH agonist. Fascinating, really fascinating case.
I mean, she should have had it too.
Right,
They just said they're going on for a long time.
I see.
So what you have to do with a lot of change.
Right.
Which we did consider. I left that out. I did speak to a surgeon.
Right.
And we talked about doing like exploratory surgery and I'm forgetting the term, ovarian drilling, where they like.
That's just a PCOS thing, but you can call 5 out and go away.
Okay.
Tumors down in the islets.
I see.
So most of these patients I see are over that somebody's had to do ovarian. I have another patient.
Hi, this is Dr. Coben. Can you hear me? And am I interrupting somebody else?
You're interrupting someone, but that's okay. We can get right back to you.
Okay. It's hard to hear the audience questions.
Oh, sorry.
Sorry.
But my very last question is, did you check 17-hydroxyprogesterone? I saw prenatal, but that was fine.
That was fine.
Okay.
Yeah, exactly.
That's it. You're ready?
What I was going to say about the surgery is we spoke to a surgeon. They felt that they would do it if we recommended it. I did also follow up with Andrea once I got to that point of the case to ask, like, should I proceed with surgery? And the patient was open to it. But ultimately, we felt like because of the timeline of her disease, to just go ahead with the Lipodystrophy as we did. Ready? Dr. Coburn?
Yeah, I'm sorry because I'm on Zoom and I can hear the speaker well, but not the audience. So I apologize if some of what I'm saying is redundant. But I was going to ask the same question that Alice asked because I didn't see a level of 17-alpha-hydroxyprogesterone, which is much more commonly seen in 21-hydroxylase deficiency, which is much more rare, much more common than 3-beta-HSD. But the other question I had is that there's some new drugs, and I'm certainly not an expert in this, but there's some new drugs for severe hypertriglyceridemia and hyperchylomicronemia that are related to, I think, the ApoC3 inhibition. And I don't know if that's relevant in a case like this where the triglycerides are very, very elevated. I didn't see, the breakdown of chylomicra and the other lipid subtypes. So I was just wondering if anybody has looked at those new drugs and if they've been used in this condition. I know about the leptin treatments, but I'm wondering about the treatments that are specifically directed to the lipid abnormalities, the triglyceride abnormalities.
Yeah, I'm not sure about those drugs. In her triglycerides were in like the 200s. We were focusing on like treating what we can treat, getting her to lose some weight and that first. So I never really considered that for her. I should have included the 17-hydroxyprogesterone in this first slide, but it was normal.
It was okay. Thank you.
I tried to keep focus on the abnormal things, but yes, it was that and it was.
Okay, and her initial triglyceride level before treatment was?
It was like in the 200s.
Oh, that's not that high. Okay, I'm sorry.
Yeah, it was weird.
No, okay, that's good.
239.
Okay, good. Okay, thanks.
Thank you.
Thank you for the wonderful talk. If patient would like was interested in getting my question, if this patient was interested in getting pregnant, are there any special considerations for therapy?
So that's a great question. So my understanding is that there's infertility associated with this because it's very severe PCOS. This patient is not interested right now in fertility, but I did speak to the OB team about her because they told her that she had some limit on Lupron, like she would only be able to be on it for 2 years, which is not true. She can be on it long term, but basically we had this conversation about how safe it would be to come off and actually get pregnant with her degree of metabolic dysfunction. So that's kind of where we're at with her case. I've never really looked into like, can you give certain medications to stimulate the ovaries? I'm sure it would be high risk. But right now, like basically my understanding is just that there will be infertility and I'm not sure what conceiving will look like for her if she gets to that point.
It's easier to get ovarian mass.
Probably not, because she doesn't have a lot of other knowledge. And I think that her degree of antigen that she probably won't have response. Yeah, you could probably stimulate her, give her the Lupron, and then give her correct ovarian stimulation. They sometimes do that. Yeah, but not really such other. You could repeat it for the Zoom people, because you have a mic. A little something.
Oh, basically, we were just saying that if the patient one day does want to conceive, she might need help with medications, and they can give Lupron and gonadotropins.
So I have a question about the epidemiology. It's underdiagnosed. We have some genes. Has anybody looked at people who have, I'm thinking clinically, about opportunities missed, patient types? So anybody actually looked at populations of people to see prevalence?
Yeah, there was just a paper here last year from people in Northwestern who's worked with sequencing a whole bunch of labs, finding that just to the labs much more thought. And I don't know that, what you do these have policies, biobanks. There's a paper from Sinai or Lonzo show just look for all these different it turns out it's much more common a lot of times. But find all this knowledge that's it's get much better understanding.
And a question. Question is on the MRI. For the MRI,
I can repeat it.
for the MRI, What kind of MRI do they use? Like, do I have abdominal MRI? They maybe mention it, someone had.
Whole body MRI, and it's,
So you would pick it up.
no, and it's not, it's usually used for research purposes, so it's not like you can like, get a whole body MRI if you suspect this. So I spoke to Dr. Garge last week because he sent the samples, and he basically said that, like the best thing we could do is just the calipers in office, because even DEXA, you don't just order a routine DEXA, you have to tell them what you're looking for, and I don't know coverage wise, you get covered for that. So he kindly offered to fly my patient down to Texas to do all the testing for her, which would be great. She's not so flexible. I also couldn't show pictures of her today because she didn't get encouraged. So yeah, it would be great. But we'll see what he finds with her DNA sample.
This is more for self about just and what described like really didn't have a response, and then like at the higher.
Maybe. Yeah. Yeah, that'd be great. Anything else? Thank you. Thank you for having me.